joining. And if you didn't know what Zoom you were joining, we're going to learn about the Michigan Collaborative for Type 2 Diabetes for New Physician Organizations. I'm Lauren Oshman. I am the program director. With me today is Jackie Rao, our program director, and then Heidi Dietz, our program co-director, is here as well. And we look forward to answering any of your questions at the end. Our agenda for the day, we're just going to give you an overview about the collaborative so you can decide if it makes sense for your physician organization. And then we're going to talk about the requirements, both for physicians' practices and the PO, and then leave time for questions. I'm going to start with overview, though, and this really goes back, and many of you may have worked with or heard of other CQIs and their role in the state of Michigan. CQIs are collaborative quality initiatives in the way that we're describing them here, and they are statewide initiatives that are developed and executed by physicians. Again, that means they're expert and physician-led, not payer-led, with funding and support from Blue Cross Blue Shield of Michigan and their HMO subsidiary, which is called Blue Care Network. They really promote partnerships between physician organizations, physicians in practices, and in some cases hospitals to create collaboration, partnership, and reward systems to drive healthcare transformation and change, relying on data then to implement evidence-based practices to improve our patients' lives. Thinking about MCT2D, what you're going to appreciate is that, again, the funding comes from Blue Cross Blue Shield of Michigan. The enrollment and membership are healthcare systems, provider or physician organizations across the state, and then organizational support comes from a coordinating center, and that is housed at Michigan Medicine, and I'll tell you a little bit more about that in a second. And then the way that CQIs function, even though the support comes from Blue Cross Blue Shield of Michigan, we consider ourselves an all-patient, all-payer initiatives, meaning that everything that we do is intended to be able to apply to every patient in the practice. And we use data that is robust, trusted, verified, incentives, financial and other benefits, and then quality improvement and change management support to help move from usual practice to a new and better state. Thinking about all of the different statewide CQIs, what you can really appreciate is that historically, many of these are surgically based and hospital based. And that makes a lot of sense when we think about cost of care and complications from surgery and where we might want to make improvements. And what we can appreciate is that type 2 diabetes is actually the most costly chronic condition for our patients. And so it makes a lot of sense that this is really the first chronic condition that was selected to be more of an ambulatory or physician organization level CQI versus a hospital-based one. And then you can also appreciate on the first column, the fourth one down, inhale, asthma and COPD was also identified as a health condition that's high cost and where intervention at the primary care and ambulatory perspective can improve outcomes, save lives, and save money. So how are we different then from some of those traditional hospital CQIs? They have this small identifiable population of all of the people who had like vascular surgery in the last year, really small group where we have specialists and small specialist teams, where we have data that's being abstracted manually by someone in the hospitals, and participation is at a hospital level. For MCT2D, we have more than 1 million patients with type 2 diabetes in the state of Michigan. And the focus, while it's not only on primary care, it's acknowledging that much type 2 diabetes care happens in the primary care setting and includes then specialists in endocrinology and nephrology. And it has all of those stakeholders. We're organized by physician organization, but there's certainly roles for communication to the hospital. And data is certainly not going to be from anyone in your practices writing things down on a piece of paper and sending it to us. We'll talk to you more about our data hub and how we pull data from your electronic health record. It's kind of a broad overview of the history of CQIs, may be something that many of you know, but I think it's for us just helpful to level set. And so now we're going to talk a little bit about MCT2D, where we started and where we're going. We were created because, as I said, diabetes is incredibly common, increasingly common and costly. More than 1 out of 9 people in Michigan have diabetes, or more than 10%. And then there's a large percentage of people who have diabetes and don't know it. even more than twice that number of patients with prediabetes who haven't yet been diagnosed. And so as MCT2D really is focused on type 2 diabetes right now, where we're going is going to be in helping people identify and prevent diabetes and prediabetes in the future. When we think about comorbidities and complications and some of the things that are most important to us, it's this idea that type diabetes is a potent risk factor for heart disease, stroke, vascular disease, and blood pressure issues. It is a major risk factor for neuropathy or nerve damage, and for kidney disease, which is probably the most costly complication of diabetes, as well as eye damage and loss of vision. And so equity issues are important to us, and we know that Black Michiganders, Hispanic Michiganders, people with a disability, people living at low income are disproportionately affected, and we'll talk a little bit about our equity focus later on in the presentation. I already kind of introduced myself and Heidi. In terms of roles and our day jobs, I'm a family physician. I practice outpatient family medicine and obstetrics at my practice in Chelsea Family Medicine. Heidi, do you want to unmute and introduce yourself since you're here?
Yeah, sure. I'm Heidi Dees. I'm a clinical pharmacist at Domino Farms Family Medicine at Michigan Medicine, and then I'm also faculty at the College of Pharmacy.
And so we kind of, and one of the things I appreciate about our team is the multidisciplinary interprofessional leadership team. What I want you to appreciate is that we have a really large coordinating center team that is here to make sure that participation in this collaborative works well, and we meet your needs and your practice and your patients' needs. And so we have two program directors, Jackie Rao and Jake Reese. We have a design team whose focus is in creating tools and communicating information and education to you, your physicians and patients, in the most beautiful and organized and user design centered way. Rina Hisamatsu is our registered dietitian. So we do have both a pharmacist and a registered dietitian on our team, and they participate in creating resources for our collaborative. And then the rest of our team, you're going to see Julian and Laria, who are design professionals, Ryan, who runs our website, Lifa, who's our administrator, and then Catherine and Neha, who are our data team. And so a large amount of effort being put into creating this robust data hub. There are physicians who are involved in leadership, and this really spans experts in different areas. Dina Grausta is an expert in research on low carbohydrate eating plans and lifestyle interventions for type 2 diabetes. Dr. Rodika Pop-Busui, in addition to being the president of the American Diabetes Association, is an expert in type 2 diabetes care and type 1 diabetes care. Dr. Joyce Lee, again, is another endocrinologist who focuses on data and diabetes. Dr. Scheinfeld-Goren and Akins are more research and program evaluation professionals. Dr. Gabison is a primary care physician focused on obesity care, and Dr. Mizukami Stout is an endocrinologist with a focus in CGM, continuous glucose monitoring. So just an example of some of the different people on the team who help us with our different initiatives in improving care. Our collaborative not only focuses on primary care, but also has initiatives focused on endocrinology and nephrology. And what you can appreciate is that we have two endocrinologists and three nephrologists, Dr. Julie Wright Nunez, Dr. Mike Hung, and Dr. Rajiv Saran, who help guide our nephrology part of our initiative. So that's our structure. There's a large coordinating center team who's here to work for you. We have 28 physician organizations currently, with over 300 practices and 1,000 physicians in the state of Michigan. And then we have a patient advisory board that really sits in the middle, and we rely on them to help us guide and determine the direction and to make sure that all of our initiatives are patient-centered. So how do we function? How do we improve? How do we change things? We enroll at the physician organization level, and so then our levers are to you and your enrolled practices. You decide which practices to enroll and how many. We together set goals and metrics, and so we'll talk a little bit more about the different goals and metrics that we have now and that we're considering for the future. And then we pull data from your electronic health record, then to create data dashboards, identify where we are as a collaborative, the variability between POs, practices, areas of the state, et cetera. And then we set metrics related to that. Blue Cross Blue Shield of Michigan, again, as the sponsoring organization, then pays physician organizations for meeting certain value-based metrics. Thinking about our initiatives, and I think this is the interesting part for me as a physician, and I'm going to cover it as a high level for you at a physician organization level. Really, we're most focused on preventing diabetes and preventing complications. And many historical quality initiatives for diabetes have been focused on check marks, right? Checking A1C, checking kidney disease, and we're really focused on what behavior changes can we make to help our patients achieve the healthiest life possible and avoid some of those expensive complications from diabetes. And so with that, there are three major initiatives. Like, we do a lot of things, but we want to have simple messaging for you. And so one of those is helping our physicians perform guideline-directed medication prescribing. The second is supporting patients in reducing carbohydrates in their diet to achieve the individualized diet plan that works best for them. And then the final thing is expanding or diffusing the use of continuous glucose monitoring in primary care practice. And the reasons these were selected is that these are three evidence-based innovations that are slow to diffuse into primary care. And these probably will change over time or be added to over time. Diving in just a little bit into each one, when we talk about guideline-directed medication prescribing, there's a couple of different aspects of this. One aspect is that newer medications, and those specifically are GLP-1 receptor agonists and SGLT2 inhibitors, have more potent effectiveness at stopping complications, at helping prevent heart failure hospitalizations, at helping prevent patients with chronic kidney disease from needing dialysis, at helping prevent heart disease, heart attacks, and strokes. And so we want to make sure that primary care physicians and specialists are able to use education about these medications to prescribe them for the appropriate appropriate patients. The second piece of this is looking at some of those historical practices. Patients who may have been started on insulin 10 years ago, when we know that it's not it's effective for lowering blood sugar, but not at preventing some of those complications. And in our guidelines now in the last few years is less and less of first and second line treatment. And maybe we want to help those physicians help their patients reduce their use of insulin if appropriate. And that is to say, both insulin and sulfonylureas not only are good at treating high blood sugar, but they also cause some negative complications with weight gain that for our patients who are dealing with both diabetes and obesity may not be meeting both of their goals. So that's some of the details about medication and guideline-directed care. Our second initiative is expanding the use of CGM, and we know that more and more CGM is becoming low cost and user friendly, helpful for patients who don't want to poke their finger a few times a day, and really may help patients both for titrating their insulin dose, but also giving them really good feedback on the foods that they're eating and how the foods that they're eating are affecting their blood sugars. I was reading a study this morning that looked at just changing someone's breakfast from a high carb breakfast to a low carb breakfast, help their blood sugar throughout the rest of the day be in more normal ranges, and can help people reduce their need of expensive medications. And so what you'll see in MCT2D is we're not just focused on prescribing medications, we're really focused on trying to help practices, help patients adopt healthy behaviors. And that's how our initiatives all work well together. The last piece of this is supporting lower carbohydrate diets. And we know that the American Diabetes Association validates a variety of different dietary tops. It doesn't have to be low carb for everybody. For many, many patients, they have been told to eat higher carbohydrate diets, and they would prefer a lower carbohydrate diet to help them reach their blood sugar goals, help them with weight loss or weight maintenance, and potentially help them stop expensive medications and reduce complications. We know from clinical studies that having a healthy low carb diet with more plant-based proteins can actually improve mortality in a retrospective group. So a really important innovation that we want to make sure all patients are offered in primary care and specialty settings. Here are some of the benefits of carbohydrate reduced diets. And I think this is, again, an area that our physician organizations have said has been really helpful in delivering information to patients. So how do we help you achieve your goals? How do we drive change? Some of this is with tools and resources. And from the very beginning, MCT2D has developed a really collaborative relationship with physician organizations, physicians, practices, and our patients. And people have told us we need help with this. We need help with insurance coverage. We need help with educating patients about low carb diet. Can you develop tools for us? Support and guidance. And we'll talk you through some of the different ways that we connect physician organizations with others working on similar goals and use our coordinating center to support you. Education, and this is kind of down to the physician level at each practice, collaborating and sharing best practices, and then using data and reporting to drive change. I'm just going to give you a couple of details about, some snippets of some of the things we're really most proud of in terms of how we're helping support you. And that means in tools and resources, we have developed guides for low carb lifestyle, for meal planning. We have a tool called Jumpstart that helps people jumpstart a low carb lifestyle. And those tools are all available and easy to use on our website. Kind of a second set of tool is helping solve that problem of I can't figure out what drug is covered for my patient. And I will tell you, I use these tools at least a couple of times a week in my own clinical practice. And so we know we're doing a good job if these are things that I say I need as well. And so you'll see here, I think on your screen, right, a screenshot of one of our user guides for private plans for different GLP medications. And in the middle, you'll see medication copay savings card, and all appreciation to Heidi for leading this work on our patient assistance program or PAP programs for patients mostly with Medicare and commercial insurance who can't afford medications. And then on the left, our medication financial assistance program guide, really helping our practice teams understand this. So in my practice, we've used these. I have a team member who submits the PAP forms, and this has just really made it easy for us to make sure that our patients get the right care when needed. The second piece about education, every one of the practice champions, and Jackie is going to talk to you kind of in the second half of the talk about the requirements at the practice level, but every practice has a champion. I'm a champion for my practice. Heidi's a champion for her practice at Michigan Medicine, is required to go through some basic training on these initiatives and then help disseminate that to the other physicians and advanced practice providers and team members in their practice. But then we have a robust set of learning community webinars, and these are typically held at noon. People who attend live are able to obtain CEUs, and then we keep them taped. And again, I've gone to YouTube and reviewed and rewatched these from time to time to brush up my knowledge about some really specialty topics. We had one most recently on CGM and helping integrate it into your EHR, on kidney disease. We had a bariatric surgeon prevent focus on heart disease. And so lots of really, really helpful training. And then support and guidance. And so there's a couple of different things that we do. And this is really mostly based on what our member practices and POs have asked us about. But we can consult with our dietitian, Rena, or our pharmacist, Heidi. So we do one-on-one consults, and we've done team-based consults. Guidance on emerging issues. So one of the tools we put out giving physicians conversion guides for GLPs when there were shortages, and then having opportunities for different sites to share best practices for each other. This is really connecting you with other physician organizations that have similar structures or similar challenges to solve problems. In terms of data and reporting, we have two different types of data dashboards, and this is really all, again, related to your EHR sending information through MyHIN, the Michigan Health Information Network, to MCT2D, so that we're able to display to you your practice's average performance, for example, on checking urine albumin tests on your patients with type 2 diabetes every year. But then also on the left, you'll see a specific tool, and these are all made up patient names. These are not real people, where you can use this to search for patients who have not had albumin testing. And at this point, we refresh this tool about every 3 months. And so it's fairly accurate at this point for you to say, I'm going to download this tool every 3 months and then use it to outreach or recall to patients. And as we go on and on with the collaborative, we are adding more and more data. And a lot of it, again, is based on what physician organizations have asked us. Can you please obtain this piece of data for us? And collaborating with our specialists and meeting their needs as well. Finally, in terms of collaboration, and you're going to hear more about the specific details about this, but we have regional meetings At this point, they're in person, fall and spring. We may convert those to a combination of virtual or in person in the future. But we have really appreciated, and our physicians have really loved getting together in a room. The thing I love most about this is that to be a physician champion, to be a practice champion, you don't have to be a physician. So we have nurses, care managers, pharmacists. We get people in a room that really represent the different team members taking care of patients with diabetes. And it's an opportunity for us to learn from each other and also to get all of that up-to-date information and updates to all of our practices. So that's really our opportunity to kind of get down to the practice level and get all of those ideas from physicians at different practices. Whereas a lot of our communication throughout the year goes to you as the physician organization, and then you communicate with your practices. So this is a really special opportunity for people to feel like they're getting together and being part of MCT2D as a team. The second thing that we accomplish every year is a collaborative wide meeting. And this is with physician organization level representatives, focusing more at that treetop view of what POs need to do to drive change in the practices. So our last meeting, we had a presentation from one of the other CQI leaders about how their collaborative made changes in their topic over 10 years. And that was a really robust conversation, as well as a conversation about health equity screening, and what different POs were doing that we could share with each other. So what's next? I talked a little bit about our health equity focus, and as a physician organization, as a CQI, and for all of you, this is very important to us. And one of the first steps is making sure that our collaborative has data on our patients with Medicaid. And so as we're bringing in data from your practices, there are other specific initiatives we have working with the state to make sure we're getting data from every patient in your practice. We are developing a health equity work group, and that's made up of different members at the PO and the practice level to figure out where we want to focus. And then M-Shield is another CQI, and they really focus on community health outreach and health equity. And so we frequently collaborate with them. And then we've been sharing how POs are screening for social determinants of health amongst each other to share best practices. The next new thing is really saying, how can we possibly help people to not have type 2 diabetes? And this really gets to someone right at the beginning of their diagnosis. And so rather than putting them on a medication like metformin and just waiting for it to progress, we're really thinking about how to support your physicians in having good conversations with those patients when they're very motivated to change, and to say, you know what, bariatric surgery for some patients helps them remit or get rid of or keep their diabetes under control without medications for upwards of 10 years. You may want to do a more intensive program at that time to go from the, pop-in hamburger diet that you have been eating to a diet that will help you get rid of your diabetes and keep it under control. And so that's something you can anticipate in the next year. And all of these ideas, I think, are based on communication with our physician organizations and what's important to them. So that's our brief overview, and I'm going to hand it over now, I think, to Jackie. Or Jackie, am I going to go through a couple more slides?
It is completely up to you. I'm happy to take over now, or it's your call.
I think let me go through the data slides, and I'll hand it over to you at the next job. I wrote it down as slide 46, and I'm on slide 35.
Yep, no problem.
And so how are we receiving data? We've gone over this, and just to kind of wrap up that conversation, we're using the Michigan Health Information Network and then MDC as our data broker to bring in data from your EHRs into this massive database that our team helps manage to output to your essentially control rates and other information that we think is important. And this is going to be a very, very powerful tool for us to change over time as we have more and more data that will include claims, clinical data, social determinants behavior data, and even patient survey data. So initially, there are certain elements that we made sure to include in this data dashboard, which included patients' A1C level, their kidney function, and urine protein. And those are some of the most important things that we track and monitor from a quality perspective when we think about CMS measures. Their prescriptions for diabetes drugs and prescriptions for continuous glucose monitors, their weight, height, BMI, and blood pressure. So important for us to watch over time if our treatment is helping people stay at a healthy weight, gain weight, or lose weight. And then just some basic demographics. We know patient gender, date of birth, zip code. Obviously, we know the name so that then we can give you that list of patients that you might want to call for interventions, and then an identifier key that helps us track them across the database. We receive claims back in the past so we can track data over time. And then we receive data from claims and clinical data to create this dashboard and give you this comprehensive view and show you how you're doing in comparison to others, and then use it to drive change to say, hey, we notice we're only submitting or only checking for kidney disease in 20% of our patients. What do we want to do to improve that, for example? How do we use that data? We disseminate information at meetings. We go through these data dashboards. We assess together and identify areas of improvement. We help physician organizations decide what they might want to improve and help them and guide them through quality improvement. And then we have rewards tiered to that and tied to that in our partnership with Blue Cross Blue Shield of Michigan. So you can just appreciate, again, a little bit closer view of those two views that we talked about. On the right, you'll see that patient list that you could use to recall patients. And then on the left, you could see that this particular practice, what their percent of patients is with an A1C measured, and then what percent is in different ranges, and a good control, pre-diabetes, or well-controlled range, up to 9, and then what percent of patients have an A1C over 9 or poor control. And then we do have quarterly reports that we're sending to each PO every month, and they are iterating and improving over time because we're getting consistent feedback and then adding other data streams. And so now I'm going to hand it over to Jackie. I think. No. Jackie, are you there?
Yes, I am. Give me just 1 second. I will go ahead and share my screen.
Awesome.
Hi, thank you, Dr. Ashman. So I am going to get a little bit more into the details around the participation requirements for physician organizations and what that looks like. So we've split the requirements for participating POs into 5 categories: administrative, attendance, quality, data, and engagement. And I will briefly go through these. We will also disseminate these slides to you afterwards so that you can review them. As far as administrative responsibilities, we're going to be asking the POs to sign some documentation to participate in the collaborative. We have just a general participation agreement and a data sharing letter to make sure that we get that data transfer set up that Dr. Ashman was talking about. The transfer is already happening, but just the permissions for it to be shared with us. We also asked for 3 roles at the PO level: an administrative lead who worked closely with us as the coordinating center and your participating sites to facilitate their participation in the program, a clinical champion at the physician organization who attends our collaborative wide meetings and helps guide the clinical quality improvement at each PO, and then a data lead who can speak with us about how data is being transmitted, how you're sharing that with MyHIN, just so that when we have questions, we're able to have someone to go to and discuss that with. As far as attendance requirements for the physician organizations, we ask that POs, the administrative lead and the clinical champion, attend our June collaborative wide meetings. So those are a half-day in-person meeting that takes place in Lansing. We also have monthly PO calls that are 30 minutes each month, just to provide administrative updates and let you know kind of what's going on in the program, deadlines you need to be aware of. We also have an annual PO MCDTD one-on-one discussion. So we set aside an hour at a time on an annual basis to talk with each of our participating POs about how their participation in the collaborative is going, where they've been able to make improvements, where they need additional support. These have been really helpful in guiding the direction of the collaborative because we want to co-develop it with you as the POs. And then we also have regional meetings, which we require the practice clinical champions to attend, but it is optional for the PO leads. Most do choose to attend those. And to provide some additional details on these meetings, so the regional ones, these are the ones that are required for practice clinical champions. They happen twice a year, first in April and May, and then in October, November, from 6 p.m. to 8 p.m. in the evenings, because we want them to be able to do clinical practice throughout the day. We require the primary care clinical champions to attend both rounds of regional meetings. These focus on collaboration amongst the sites, sharing best practices, and cover topics of clinical relevance to the practices. And then, like mentioned on the previous slide, we also have our annual collaborative-wide meetings once a year in June. We require the PO clinical champions and administrative leads to attend that. We review data and progress on quality initiatives. We discuss specific topics and allow for collaboration amongst POs. So moving on to the data requirements, we ask that you meet submission standards, including completeness, timeliness, and accuracy. So really the data that we're working with, like Dr. Ashman had covered, we primarily use the provider payer quality collaborative data, PPQC data, that most POs are already submitting to MyHIN to meet those requirements. But there are sometimes fields like weight or BMI or serum creatinine or different ones related to the collaborative that aren't being completed to the full degree that we would hope to see. So we've been trying to work with POs on increasing submission of those as just an example around the standards there. Work with your practices to ensure the completeness of data. Partner with the Michigan Data Collaborative and us to improve the data submission process. So an example of this recently is we've been having one-on-one calls with POs to just discuss their current submission rates, any challenges they're facing, how we can support them, how MyHIN can support them, how MDC can support them to increase that rate. So just partnering together to try to talk through the data elements. Working with us to submit additional data. So we do patient-reported outcomes. We're interested in getting remote monitoring data from the continuous glucose monitors. So working with us on trying to increase those data sources, and then allowing data to be used in peer-reviewed publications to advance the QI efforts. Around engagement, so we would ask that you identify primary care practices who meet MCT2D participation requirements and recruit them to join the program. I'm going to talk a little bit more about what our participation requirements are for primary care practices, and also following this meeting, share a large overview document with you that covers the requirements for the clinical champions and for the other roles within the program so that you can review that. We also ask our participating POs to identify a patient advisor to serve on our patient advisory board that is representative of the population that the PO serves. We also have you, as the PO, serve as the primary communicator for the practices. We do reach out to the clinical champions and let them know of updates and things going on in the collaborative and sharing resources, but you as the PO have a closer relationship with these practices and are meeting with them more frequently. So we ask that you share things with them as well and make sure that they're on top of what is going on within MCT2D. And then follow up with practices to ensure their completion of the value-based reimbursement requirements. So again, just kind of supporting us and being that outreach to your participating practices. And then quality, we want you to coordinate with our team at the coordinating center and your participating practices to advance performance on the initiatives using the data from the dashboards and the information that we share in the regional collaborative-wide meetings and the tools that we develop just to help improve type 2 diabetes care. And then also participate in panels and share your experience with the other POs participating in MCT2D. As a collaborative, we really want to learn from each other and share the successes that we've had so that we can support others who are in different phases of this work. So I talk a bit about the payment structure and how that works. I'll get into on these next few slides the payments to the physician organization and how the value-based reimbursement works. So for participation support in MCT2D, there is a fixed PO reward that's paid annually in July. So POs can earn up to $75,000 on an annual basis to support infrastructure that you need to participate in the collaborative. And that's based on the completion of our PO scorecard, which I'll go into some details on the next slides. Then Blue Cross Blue Shield is evaluating both the variable PO reward and the practice recruitment reward right now, and we'll have more details for you in February on what these final amounts are. But historically, Blue Cross Blue Shield had a per patient reward for participation in the collaborative that was based on the type 2 diabetes patients and your participating practices. Like I said, they're looking into potentially restructuring that, but there will be a variable PO reward for participation in MCT2D that they'll announce, and also a practice recruitment reward as well, whereas for each practice that you bring onto the collaborative, you earn X amount. Again, they're determining the exact details of that, and we'll have full details in February. And then at the physician level, there's a 5% value-based reimbursement for all participating physicians in MCT2D based on meeting participation and in the future performance metrics. For practice eligibility to participate in MCT2D, we have the following requirements. We want practices to have an EMR. That will be required in order for that data that makes up our dashboards to be submitted. And then Blue Cross would like the practices participating in MCT2D to either be a provider-delivered care management practice with over 20 total type 2 diabetes Blue Cross patients, and that's going to be across their commercial PPO, their PPO Medicare Advantage population, Blue Care Network, and the Blue Care Network Medicare Advantage population. So across those, they have to total 20 or more if they're a PDCM practice. If they are not a PDCM practice, but they must be a physician group incentive program practice with over 75 total diabetes patients from Blue Cross Blue Shield. So right now we got the initial counts from Blue Cross Blue Shield on type 2 diabetes patients. We're matching that up with information in the PGIP list around if practices are to provider delivered care management practice or not. And we'll share that with you individually so that you can see which of your practices and your PO are considered eligible for participating in MCT2D so that you can both have that help you in your decision to join the collaborative. And then when it does get to the recruitment stage, like who you may want to bring on board. So as we discussed on a previous slide around the PO scorecard, to earn that $75,000 annual payment, there must be completion of the requirements of the scorecard. We have a scorecard for POs that are brand new to the collaborative, and then a scorecard for ongoing POs that will change each year. So the scorecard for new POs will be really reminiscent of the requirements that we just went through as far as participation. So did you sign your participation agreement? Did you recruit your practices? Did you identify those contacts, the lead, the clinical champion, the data contract at the PO? Did you attend the kickoff meeting? Did you go to the PO check-in meetings? And have you attended things like the collaborative wide meeting, et cetera? So it will be, like I said, reflective of those requirements that we asked in those initial slides. And as long as you meet all of those, you'll earn that full $75,000. And just to give you an example of what this looks like for the ongoing POs, once you're more established in the collaborative, here is like a high level of what we're asking for participants that are currently in MCT2D. The scorecard totals 100 points, and the points earned will be commensurate with those earned on the scorecard up to 75K. Sorry, there should have been a K after that. So we have things that are similar, like attending the required meetings of the collaborative. We have things around the data. So completeness of BMI and A1C data, maintaining the contacts at the organization, communicating with practices around regional meeting registration, supporting practices and the QI work, et cetera. So like we said, really related to what you've seen in the requirements that we've detailed. This is just kind of a formalization and a tracking of those, and that will tie to that payment amount. And then for the physician or the practices that join from your physician organization, this is what the value-based reimbursement requirements for those practices will be. And like we said, we'll share out this PowerPoint so you can refer back to it and share this with practices that may be interested in joining the collaborative. But we're asking the practices also identify a practice clinical champion and what we're calling a practice liaison. That should just be an administrative contact at the practice. We'll also have practices complete our MCT2D trainings. So we ask that the clinical champion attend these virtual on-demand sessions. We offer CME for them, and they're around the quality initiatives that Dr. Oshman introduced in this presentation. So low-carb diet, guideline prescribed or directed medication prescribing, and continuous glucose monitors. So they're meant to get the practice to like a base level of knowledge on all of those and introduce them to some of the resources and guidance that we provide as well. We would also ask practices that join this year to attend the spring 2025 regional meetings in person. Again, the clinical champion will be the person required to attend those. We'd also ask the practices to complete the practice change readiness assessment. This is a brief survey we do of our new sites just to understand where they are with the QI, how their practice is set up, et cetera. We also want to do a patient needs assessment with new practices that patients will be completing and collecting a minimum of 10 responses of these per practice. We would ask the practices to report back on what they've learned from that patient needs assessment. And then we have a brief physician level survey, again, similar to this practice change readiness one, where we're just understanding as new physicians join the collaborative where they are with these initiatives, with the work that they're doing with patients with type 2 diabetes. And then we have something called our MCT2D learning community, and there's different option levels. We have one that each physician must do one of the options, one that each practice must do, and then one for the PO. So we have this as an annual recurring item on our value-based reimbursement that each year we add new options and give them different ways to meet this. Also wanted to let you know, and this will be in the follow-up that we sent from today's meeting, we'll be doing an intro to MCT2D for practices exactly a month from now on February 22nd, where we'll go into a lot of detail for the practices on this scorecard and around the requirements so that they know what they're signing up for, and so that the burden of communicating all of that isn't on just you as the PO. So those practices you have that may be interested in joining, we're offering a very similar session to this one with just a little bit more focus on the practice that we'll include for you as well. So just as an example for that learning community requirement, which was the last one on the BBR, we have many different ways that the physicians can engage with us to earn that. Dr. Ashman had discussed the learning community events that we offer. We offer 10 of these a year. If physicians attend them live, it counts for this requirement, and they also get CME. If they watch a recorded version, they still get credit for meeting this requirement for us. We've created a ton of tools. Dr. Ashman showed just a really brief intro to some of the tools that we have. We want to get feedback from the physician practices using these so that we can ensure that they're helpful. And so we ask for feedback on those and make revisions based on the feedback that we get. We also offer at MCT2D a CGM user experience program where we've partnered with Abbott to offer a freestyle Libre for patient or for physicians to be able to try and understand the experience of using a CGM from a patient perspective. We've gotten really good feedback on these from our currently participating sites that it really helped them to understand like what using a CGM is like and has made them like more comfortable prescribing them to patients. So participating in that program also meets the physician level requirement. We wanted to make these easy and achievable and still value added to the physicians knowing how busy they are. So that's what we have is these level of requirements, and each physician that's earning VBR as part of MCT2D would need to complete one of these. We have practice level ones. Again, these are a bunch of options that we change and update and add to during the year. Submitting feedback on a patient-focused tool, connecting with another practice using our best practices database, giving user experience feedback on like our dashboards or our website. We really want to be able to continue to improve the things that we offer and make sure that it's meeting what the collaborative needs. So in order to do that, we want to talk with the participants in the collaborative using them, sharing a dot phrase in our dot phrase library that provides EMR shortcuts and helps the practices like more easily prescribe things and not have to reinvent the wheel writing their own phrases, and then participating in a review of SDOH. We had a question in the chat. Is there data on improvements in care from the initiative that can be shared with providers in order to encourage participation? Yes, we could share some overall collaborative-wide data on the increase in prescribing around the SGLT2s and GLP-1s and the decrease in insulin prescribing and the increase in CGM prescribing that we've been able to see as the initial results of the collaborative. So we'll be happy to pull together that information. And our team is currently working on an analysis around HbA1c rates and how those have changed their participation in the program. We don't have that analysis ready as of yet, but it's something that we're working on. And if it is ready during the recruitment process, we'll share that as well. And then finally, for our learning community requirements, we have PO level ones. Once this is completed by any person affiliated with the PO, it counts for the entire, every physician participating in earning VBR. So that's things like, again, kind of higher level, more extensive tasks, because we want to start with the physician ones, make them as easy and achievable as possible. The practice ones are a little bit more intensive, and then the PO ones are the most so, because once they're met, they count for every physician within the PO. So being interviewed for a blog, participating as a panelist in one of our discussions, adding an additional patient to the advisory board including in addition to the one that you're required to as part of participation in the program, or else participating on our steering committee. So the next steps for those who are interested in potentially joining the collaborative. So first, just wanted to let everyone know that we have 4 spots for physician organizations to join MCT2D. And we'll have each physician organization able to bring on up to 5 primary care sites in their initial year of participation, and however many specialist sites that you want to have enroll. We also have endocrinology and nephrology that can join the program. We'll get into more details of this for sites that do join MCT2D because that recruitment doesn't happen until late fall. We'll review PO applications in partnership with Blue Cross Blue Shield to determine who those 4 spots will go to. We'll be considering factors like the geographic location, if your PO works with underserved population, your involvement in care management programs, and other factors in order to make the decision on who to enroll in MCT2D. So next steps following this meeting. After this meeting, I'm going to send out a couple things. One, we'll send out the recruitment packet that has additional details on the roles within the PO and within the practices that are met. We'll send out a copy of these slides so that you can review it. We'll also post this recording as well in case you want to share this with others in your organization who weren't able to attend. And we'll also disseminate a link to your PO application. So this PO application will take you to just a brief survey that asks a few questions about your PO that includes some of the factors that we're deciding for participation that were mentioned on the previous slide. And we're asking that you submit that application by February 23rd. After you submit the application and we've determined the participants, we would have you complete the participation agreement and the data sharing agreement. Then between February 22nd, when we're going to open practice recruitment, and April 19th, we would want you to enroll eligible and interested primary care sites. We'll also share the registration link for our webinar with you all for interested practices. And then once you are officially part of the collaborative, you've enrolled your primary care sites, we do PO onboarding calls with each new PO just to orient you to the collaborative and learn a little bit more about your organization. And then your participating sites begin participation in September 2024. So those initial requirements are what we talked about earlier in this presentation around identifying a clinical champion, completing a practice level administration or practice level a readiness assessment, and then completing some initial trainings to participate in the collaborative. So a lot of work between September to December, just getting up to speed and onboarded onto the collaborative. So with that, wanted to pause and see what questions everyone has and make sure that we leave some time to answer anything else. You can either unmute or feel free to put questions in the chat and we'll pause and give everyone a few minutes. Okay, well, not seeing any questions come in. Like I said, we will send you follow-up emails shortly. One question. Are the regional and collaborative meetings in person or virtual? The collaborative-wide meetings that the POs are required to attend in June, that half day, those are in-person meetings. And the regional meetings that the practice clinical champions need to attend are in person as well. We felt like the collaboration that happens like in those in-person meetings is really vital, and we've been able to create like very good relationships between our participating sites like through those. So yeah. Next question was, when would a PO find out if it's accepted into one of the 4 spots? It would be by the end of February. So we would want to leave it open till the end of our application window, and then we'll let you know shortly afterwards. So should still have about like 2 months if to enroll those practices. All right, we will follow up with you with the email shortly with these slides, with additional information, with the link to our practice informational session, and any other information that you need. Please feel free to reach out. Another question, we'd like to join, but we were hung up during the collaborative because we were not a part of the health information exchange advice. So Warren, do your practices submit, and does your PO submit PPQC data or any data to MyHIN?
So I'm at Wayne State University. We have a huge practice, but we use this kind of Byzantine medical record called Athena. And when I approached them about sharing data, they threw their hands up and thought it was going to be a major effort to make our electronic record compatible with the information you were requesting. I am a tech illiterate. So, I'm past, I still have problems using a cell phone. But I also understand the value of this because I used to be the Assistant Secretary of Defense for Health Affairs and had, 6 million patients that we dump data on. And if they could do it, I'm certain we can do it. But I just need to have somebody that would be able to work with our IT folks because they just think it's too prohibitive a task to make this exchange possible. And I can't argue with them because I don't know enough. So any help that you could give me, we at Wayne State University would be delighted to join the collaborative otherwise.
Yeah, Warren, if it would be all right, if you want to send me an email and I'll put my email in the chat here, and I think everyone has it, but just for easy access, if you want to email me with and include your IT people on the email, we can maybe set up just a really brief conversation to understand like what's currently happening, what's currently, if anything, being submitted on behalf of Wayne State, and see if we can get to a place where it would make sense. So we'll get the right people on the call and just have a discussion about it.
All right. Thanks much.
Yep. All right. Well, thank you everyone so much for joining. We really, really appreciate it. We look forward to you potentially engaging with the collaborative, and we will be in touch very soon.
Thank you.
Thanks all.
Thank you.